don't know how to advance if this is the one. Okay, so good morning everybody. Good morning everybody. Just a few slides to give a rapid overview of how COVID was managed in Italy. As you probably know, Italy is the second country for number of people interested by COVID. Rapidly and went above China at the end of March, as has been overcome only by United States recently. So we have a very, very huge number of cases in Italy with very severe consequences, especially in the north of, wait a second. I have a few. Okay, sorry. In Italy, as you know, the north of Italy has been especially interested. I have not very significant direct experience with the COVID management because Naples is here, as you know, and the big problems were in the north of Italy. And even with the spreading of the pandemic, mostly remain localized in the north and in the upper center of the peninsula. And the Naples remain so far with less than 3,050 cases. So not so many cases if compared to the big troubles that were observed in the north. Positives, we are in approximately in a plateau phase, both for the positive number of cases that are decreasing slowly, but still, unfortunately, in a plateau phase for the number of deaths that is approximating between 500 and 600 per day. So we are still in a very active phase of the pandemic. And fortunately, there is some improvement in the number of admission in the ICU. The plateau was reached at the beginning of the month of April, and the admission of ICU is slowly decreasing in the last days. So this is a good point. The mortality rate per 10,000 inhabitants is very variable according to Italian region. The highest mortality rate is in Lombardia, the region around Milan, in the north of Italy, with a 10.18, and is very, very limited in some more southern countries like Campania, where Naples is, where is lower than one mortality per 10,000 inhabitants. So very significant geographical differences in Italy, as you all have experienced in your own countries. And this is the area of Milan, and this is the area of Naples. You see that the numbers are very, very different, with active total cases of more than 30,000 in Milan and 3,000 in Naples. So my personal experience with COVID is very small, and I will just report how a few things have been managed in the region where the situation was very, very bad. For example, in the region of Lombardia, a Milano region that has an excellent network of a public health system, there were only 720 beds in the ICU, and at the moment there are 1,200 COVID patients admitted in the ICU. So a huge gap, and they really did miracles to create a huge number of beds in the ICU in the region around Milan and in the upper Emilia-Romagna region. So really very, very strong effort in order to create it. And how neurosurgery was involved in this effort, a very significant participation, because of the reduction of all surgical activities, starting with elective and then emergency cases that were reorganized completely on the territory, and subspecialty shift of ICU facilities and anesthesiologists to the care of COVID-19 patients. So all anesthesiologists, or the large majority of anesthesiologists, were shifted to the care of COVID patients, and many neurosurgeons as well were ordered or volunteer to take care of COVID-19 patients. The regional government asked to estimate, the first step was the estimation of the number of true neurosurgical emergency procedure and of non-deferrable elective ones for a foreseeable period of 2 months, in order to reorganize and to see what was the real need of neurological surgery in that very, very hot area. The evaluation was of 80 to 100 emergencies per week. That was the estimated number of surgical emergency. Approximately the same number of procedure was estimated as non-deferrative elective cases, most tumors. So this was the estimate, and on the base of this estimate, a completely different system was created. That means that out of more than 15 neurosurgical departments, all the urgent neurosurgical activity, mainly trauma and vascular, were shifted and managed in only 3 centers that were the Niguarda Hospital of Milan, the Brescia Hospital, and the Varese Hospital, that are 2 cities around Milan. And then for the tumor cases, all emergent tumor cases were managed in the Neurological Institute Besta, that is a long-standing tradition of tumor management in the area of Milan. So this is the area around Milan. The 3 arrows are the 3 centers, the 3 hub centers that were elected for emergency cases, and the green arrow is the Besta center that was elected for the management of tumor cases. All the other centers that you can see here, Sondrio and Lecco, and all the others blue spot, were only dedicated to the care of COVID patients. So with this system of hub and spoke, basically all neurosurgical units in the spoke hospital gradually became inactive within 1 week, a completely stop of the activity, and all neurosurgeons and all anesthesiologists were shifted to COVID hospital. The number of neurosurgical departments managing emergencies was reduced in a very short time from 15 down to 3, and some minimal activity was occasionally still performed at spoke centers only for very critical cases that could not be transferred with impending danger of life. Of course, all the hub hospital for emergency have neurosurgical trauma, stroke, and endovascular 24 hours a day, 7 days per week. Thanks to the cooperation and collaboration of more than 20 neurosurgeons from spoke hospital, and also for some spine orthopedic surgeons, the number of on-duty neurosurgeons at hub hospitals has doubled, and neurosurgeons agreed to move from the spoke hospital to the hub hospital volunteer. Some of them were ordered, but most of them were volunteer. And in addition to each hub hospital, 1 on-call service of complex spinal surgery and 1 of vascular surgery were set up. My friend Corrado Iaccarino, who sent that most of you know because he participated in the IFNE workshop that we do in January, that works in the very, very deep part of the COVID hell in the north of Italy. He volunteered. He was canceled completely his neurosurgical activity. His department was closed, and he was elected head of the department of COVID triage in the emergency room of his hospital. So he's been doing a completely different job in the last month, and he really sent me also these few numbers about the numbers of people who volunteered in other cities like Legnano or Monza or Parma or Turin, and the numbers, the huge number of new COVID beds that were created. And for example, in Legnano, 6 staff neurosurgeon volunteer. In Monza, 9 were ordered and 5 volunteers, and in other cities, all volunteer to take care of COVID patient and to abandon temporarily the neurosurgical activity. So in 2 weeks, what happened in this hub and spoke system? In the first 2 weeks, a total of 83 surgical cases were managed, a number that was much lower than expected. In fact, this was mainly related to people being confined to their home, no more car accident, with a decrease in the activity leading to a significant reduction in trauma. And intriguingly, we also observed a reduction in the subarachnoid hemorrhage and strokes. And this hardly finds a straight explanation, but this is what was observed. So fortunately, the number of emergency in these first 2 weeks were lower than expected. 15 COVID-19 patients had undergone surgery, 9 had a regular course, 5 patients died, and 1 patient is in critical condition, and all of them because of pulmonary complication. Of course, all surgery on COVID-19 are conducted inside specifically dedicated operating rooms. The patients are admitted to dedicated ICU or dedicated wards, depending, of course, on their status. And of course, as you all know, when performing surgery on COVID-19 patients, all operators are required to protect themselves with double gloves, double surgical gowns, surgical 995 respirator mask, and disposable face shields. And there is a lot of experience and of tales about how neurosurgeon manage this shift from neurosurgery to take of COVID. Most of them were volunteer basis and made choice to actively participate in the COVID-19 patient care. And after a short training with tutorials and MOOC on acute respiratory failure, neurosurgeons of, for example, of Ospedale Maggiore Policlinico in Milan are completely and fully involved in the care of patients with COVID-19 in a medium intensity 31 beds COVID-19 ward. So a whole ward in the University of Milan has completely stopped every neurosurgical activity and is only taking care of the music. Okay. So the creation, of course, for the discussion of tumor cases, the creation of web-based platform for conference call and sharing radiological images. Patients were categorized according to the severity of their illness into 3 classes, following many of the classification that you can find in many guidelines all over the world. A++ is a patient that must be treated within hours because of rapidly increasing intracranial pressure, impaired consciousness, and symptomatic medullary compression. A+ is patient who requires surgery within 7 to 10 days for intracranial tumors with relevant mass effect on progressive neurological deficit. And the A patient just has a lower level of urgency requiring treatment within 1 month. And he's rescheduled and rediscussed. A++ cases are performed at one of the 3 hubs in around Milan with an emergency department, or in selected cases at the spoke site whenever possible, but only when mainly these cases cannot be transferred or there is a real impending danger of life. A+ and A patient are referred to the neurological hub through an interinstitutional board reviewing process that is managed by the Neurological Institute of Besta, Milan, where there is a strong tradition in tumor management, and they can manage this case and schedule this case. Each patient that has to go into elective surgery, of course, has a measures amount of body temperature, O2 saturation, complete blood cell count, C-reactive protein and transaminases, chest radiography, pharyngeal COVID swab, and comprehensive interview focusing on COVID-19 for the patient, for the whole family. And in case of COV2 COVID positivity, surgical indication is rediscussed based on some preliminary unpublished data suggesting a higher risk of morbidity and lethality if surgery or neurosurgery is performed in COVID cases. So this indication must be rediscussed, and real good and real positivity of surgery must be really evaluated in the light of the positivity for COVID. So there are also in the neuro-oncological hub, there are also some chemotherapy has been delivered, so it is possible with very significant protection for both for the patient and for the care. For the pediatrics, we have 5 departments of pediatric neurosurgery in Italy, in a purely pediatric hospital, and our hospital is in Naples. With our hospital has 430 beds and 14 ICU beds. As you know, the disease is much less severe in children if compared to adults. The main risk is for the hospital staff, because also the course of the disease is more favorable in children. We had 137 suspected cases, and the confirmed cases with only 3. So it's really very low number of cases among patients. In the staff, instead, we have a more higher number of positive cases and confirmed cases with 3 with the PCR swab and 5 with significant symptom and positive CT. So a total of confirmed case of 8 cases in the staff. So it is a relatively low grade and low level of infection in our hospital. The swab and the first evaluation is done in 2 tents that are positioned outside of the emergency room in our hospital. And there are 2 beds in the short stay observation that are dedicated to hypothetic COVID patients. And there are 2 beds and 1 bed in the neonatal ICU that are dedicated to COVID patients that fortunately we have not used until now. The hospital organization is basically the same as for other all other hospitals that you have. Access to entrances is severely restricted. Visitors are limited. Outpatient visits are reduced to only usual cases. Follow-up neuroimaging is cancelled with MRI that is basically stopped only for emergency. Telemedicine encourages, and of course drastically reduce elective surgery. Each case is prioritized based on the level of harm over the anticipated delay on care. So we basically postponed craniosynostosis, asymptomatic occult spina bifida, asymptomatic cases, cyst, laser ablation, and functional, and we schedule oncological cases, CSF disorder with intracranial hypertension, and severely symptomatic cases. And in case of flu-like symptoms, of course, surgery is postponed. So it's basically just a good sense advice in order to reposition on your activity. Mainly, we operated in these last months of trauma, hemorrhage, hydrocephalus. We are the only pediatric neurosurgical department in the south of Italy, so we have to take care of most of the tumor, especially, and hemorrhage emergencies in this very large area. We try in the OR to limit the number of care providers with strict gowning and barrier protection during intubation, extubation, patient handling, and positioning. I encourage everybody of you to read this letter published on neurosurgery at the beginning of the month about the neurosurgical treatment algorithm. It's too long to go through, but basically reflects, and we inspired also to this letter in order to take care and to take some advice on how to do, but it's very well done, maybe very complex and highly complex. Something can be simplified, but it's good to have classification according to the level of involvement of your hospital and of the level of specialization of your hospital, and to stratify your involvement and your precaution according to the degree also of your region. Some just few slides, and I'm finishing about perspective on the new generation PPE. According to the first papers and the direct communication from Wuhan and from colleagues in China, saying that the basic standard N95 max and even double glowing are not sufficient, for example, for surgery in the nose or in the pharynx or in the area. Of course, we have to think about a new generation personal protective equipment, for example, the so-called PAPR, the powered air purifying respirator, that according to the Chinese colleagues has been the real shift in the number of diffusion of cases in the personal, in the operating room and the ICU. This is a powered full face mask or some kind of mask that is more easily done and used in the ICU. For example, see how an ICU ward is organized in South Korea. This is the way a nurse take care of COVID patients in South Korea, and this is the way we should do and we should use in order to avoid multiple layers that are very complex to use. And certainly this is a kind of equipment that should be used. Then safe intubation. Safe intubation is very important, especially for anesthesiologists or for emergency case where we have no time to do all the swab and all the tests, and just people with very severe respiratory distress coming into the emergency room. Very cheap and very genial way is the way these guys in Boston found with this simple plexiglass blocks that is being recently published in New England Journal of Medicine, where you can perform a safer, much safer intubation with a physical barrier between the operator and the patient, and you can manipulate this. And is this effective? Yes, this is effective, because without the box, they simulated a cuff and they simulated the explosion of a small balloon full of fluorescein, and they just saw how the fluorescein was expanding on the face and of the mask and on the shield, on the neck and on the hands of the operator, whereas with the box, this explosion was drastically limited by the presence of the box, and there was absolutely no diffusion of the fluorescein outside of the box. So this is very cheap to do. This is incredibly intelligent and smart solution. You see that all the diffusion is limited only inside the box, and the operator is perfectly clean on the fluorescent ultraviolet lights that is able to see that the guy is completely free of any kind of contamination. So very, very smart, only a few euros, and you can be extremely safe in your intubation. And then the next generation that we are going to buy in our hospital for ENT surgery is the aerosol aspirator that are already used in dental surgery. But you can see that there is an aspirator of aerosols that are produced during intra-mouth and intapharyngeal surgery. You can see that this is already used by dentistry and by odontostomatological care providers, and you can see that all the aerosols is immediately aspirated in a closed system, and it is very easy to use. So to conclude, this is a big thank you to all the care providers in Italy who manage a huge pandemic and a very, very dramatic situation. And I remember to all of you that many doctors died during this pandemic in Italy. There is a website that is updated every day on the number of doctors and nurses that die. We are in Italy so far at 131 doctors who died and 30 nurses that died. So stay safe, take all the precautions you can in order to do your work safely, do your work, but work safely. And a big thank to all our colleagues who give their life in order to continue to work. Thank you very much.
Thank you, Pepe. It was wonderful. I think an excellent presentation. I think what's happened overall, it's really dedicated to all the doctors all over the world that have done a wonderful job. Not even doctors, I think the whole healthcare industry has worked with knowing that they were thrown into the deep end without gear in many circumstances and giving their life away. I think we should all try to protect that and make sure it doesn't happen again. What we'll do is we'll have the questions at the end of the three talks. So we'll move to Zhao Peng. Zhao, are you there? Can you please share your slides with us? Zhao, can you hear us?
Okay.
Emad, can
you hear me?
Yeah.
Okay. I can. Okay, I can start.
Yes, you have 10 minutes. Let's quickly get on with it.
Thank you, Chairman. Maybe my professor, Professor Zhang, Yazhuo Zhang, maybe come here. Can he see something? Maybe he can say something, or I can start.
You can start, and maybe in the end he can say a few things that he wants to say.
Okay, maybe I start first. Maybe my professor some problem with the internet. Okay, I share my screen.
Yeah, please.
Okay. Can you see?
Yep.
Yep.
Okay. Thank you, Chairman. The professor's colleague, good evening. Just in China, it is the evening time. I'm Dr. Zhao from Beijing Tiantan Hospital. I'm very happy to share our experience for this special time and to prevent COVID-19. Although I'm not in the, we are not in the center of the epidemic, Wuhan City, but our daily work may be similar with you all. So I think my presentation may give you some advice. So today my topic is neurosurgery in the popularity of COVID-19, Chinese experience for prevention and control strategy. With the spread of the coronavirus disease worldwide, the number of infected people continues to increase. Till this data is the last day. Just in China, there are 83,000 confirmed cases, but in the world there has 2,071,000 in the world. So today it has been increasing more, maybe. The new coronavirus is just the introduction for the new coronavirus is a SARS-CoV-2 2, and also it was defined by the WHO for the COVID-19. So the epidemiological characteristic is different just for the source of infection, the root, the suspectable crowd. The source of infection is the COVID-19 patient or asymptomatic patient. Nowadays in China, we just treat the asymptomatic patient is very important. The second is the root. We think the respiratory droplets, the close contact, the high concentration aerosol is very important. So nowadays we just treat this different people with different method. And we think the mask is very important in China to protect. Also, the suspected crowd, the population is very, is the generally suspectable. For the Chinese success, we think we must separate the different kind of people, just not the crowd together. This is very important. But you know, in US, it's so more crazy for the people get together. It can increase more. This is Chinese experience, I think. So for the clinical features for this kind of COVID-19, it has the common symptoms, the rare symptoms, the severe symptoms. But for the normal people, they have no symptoms. But for the severe symptom, it's just for the dysphagia or the shock. So it's very dangerous. The incubation period is from the 7 to 14 days. So the 2 weeks is just more important for the people. Nowadays, we in our hospital, we just have some measures for the admission, just as this slide showed. We admission the screening. All these four levels must be needed. For first is epidemiological history, and the blood test, the CT chest CT scan, all the 2-time COVID-19 PCR test. Nowadays, this PCR test is very quick in China, but it's not I think it's not the maybe the positive one. Also, we have some new methods. And another, the operating room must be selection for different kind of position, different kind of situation. For the non-emergency patient, we can send this patient to the general operating room. For the emergency patient, we must send the patient, we must complete the COVID-19 PCR test, then to the emergency operating room. But the more important for the confirmed, all the suspected patient, we can send the patient to the negative pressure operating room. It's more important, but because this is a very dangerous case. And also in our ward, we just separate one part for the transition ward. The transition ward is a full treat for all the emergency patients who are not complete screened. All the patients who tested negative for the 2-time test, PCR test, was transferred transferred to the general ward for treatment. Just for the protection, just the Cinalli, Professor Cinalli gave us that we just defined the level for the protection to the 3 levels: the low, the medium, the high protection. The low is just the normal. We just wear the mask and wear just the hand hygiene, the worker clothes, and then. But for the okay, maybe for the effect for the medium one, we must just make it much more protection with the N95 mask, and then face screen, face shield, and the single layer gloves. But the high protection must maybe the exposure to the aerosol or body fluid, just as the maybe the trachea, maybe the respiratory, the oral care, also with the CSF fluid. We must with this kind of high protection. we need the protective coverall clothing, and then the N95 mask and the face shield and double layer gloves is just the highest level. For this is if we meet the COVID-19 positive patient, we need this kind of just Cinalli gave that machine. So this is the highest. The inner layer just okay. The inner layer is this, and the outer layer is this with the sheath. Also, the C is with the hood without PAPR. But the highest, the most important is the outer layer with the hook with the PAPR. It's very heavy, but it's very useful for treat the COVID-19 patient positive. So if we wear this kind of PPE, maybe some difficult to do operation, I think. So in our hospital, this is a flow chart. We treat, diagnose, and treat the process for the patient. Just the principle is early detection, early reporting.
Sorry, Zhao, I'm sorry, we can't see your screen. Screen share is gone. We are seeing you now.
Okay, I just maybe share.
Yes, please.
Okay. Oh, what's problem? Oh, I can't. Okay, I share. Maybe somebody share the screen.
Ahmad, can you fix this?
Yeah, I share the screen. It said the chairman, the president, forbidden.
No, you haven't shared your screen.
Please share your screen again.
Yeah, I share. Also, it said the share the screen forbidden by the. Oh, what's the problem? That's the way. Maybe there's no.
Ahmad, is there a problem at our end?
Sir, 1 second. Can you try now?
Okay, I can share. Okay, can you see?
Yes, now we can see. Please carry on.
Okay. Sorry for the some problem.
No
so
problem.
The diagnosis and the treatment process for our hospital is follow this flow chart. The outpatient, we descend the patient into two groups. The 37 centigrade lower, we can go to this part. The common patient, just as our normal operation.
Sorry, Zhao, can we speed up because we're running down out of time, please?
Okay, I just quick. Okay, and then with the emergency patient, we just with screening and then to the transition ward and then to the general ward. But for just quick. Okay, for the emergency patient, we must first for the emergency rescue and do the chest, the screening, and then to the transition ward and then to the general ward. But for the high body temperature and the COVID screening is positive to the designated hospital. And all if in the middle we find the patient with COVID screen positive, all to the designated hospital. This is our hospital flow chart. And nowadays our work is different for two places. This is a fever clinic, and this is online free clinic, and also our normal outpatient clinic. Nowadays we do operation. This chart see the 2 months we do the endonasal surgery and the craniotomy. So all the patients with the screening, we have no positive one, but all the patients recovered very well during this period. So our our experience facing COVID-19 pre-hospital management, we must screening, and also the patient must wait for 14 days and come to the hospital, and also wear the mask protection. Also, in the inpatient in hospital management is different for the we just separate for clean area, the contaminated area, and the potential contaminated area is separate place. And then for the post-operative patient is different from the ordinary patients, emergency patients, and also with the suspected patient to the designated hospital to treat this COVID-19. So just the neurosurgical operation, this slide showed that we have some cases we must treat the patient very just protective. And then I think the pre-anesthetic assessment is very important. For the tube, tracheal tube intubation is very important because we just meet direct to the respiratory tract. And also, this is the endoscopic, our endoscopic transnasal surgery. The experience is similar with the Stanford recommendation. Just several days ago, they sent to us. Just we have nowadays we have no infection for the COVID-19. Okay, so and the other important strategy for you all, I think the psychological pressure is very important nowadays, not only for our staff, but also for the normal people. So nowadays we have some course for relieve the psychological pressure. Also, we have the training daily medical care practice. All our staff have this technique, skills. So now just to the conclusion that take home message. So the international cooperation is a key defeating the COVID-19 worldwide pandemic. What are we doing? That's the several days ago, Professor Schroeder and Cinalli and Luigi and Sandy read me letters, and I gave them our experience. And then I have some research paper to the World Neurosurgery. Also, last week we have this education, the online education are very important. Also, I think in our government, we have the international help. I think maybe all of you have help by the China to maybe to Italy, to Germany, France, Pakistan, India, Japan, Korea, Serbia, and others. I think all we are a community to share the future for mankind. This is our dream. This is also our aim. So this is the last one. We think in the future we maybe not soon we can defeat the disease, and then we can come together to share our achievements. Okay, thank you all.
Thank you, Zhao. Sorry that I had to rush you there. I apologize. You're just running short of time, and I wanted to make sure that Henry gets his time with his colloid cyst that he has to present. So what I'll do is I will just quickly go through my slides because majority of it is already done. And so I don't have to, one second, what did I do there? Okay. Let me, okay. So can you all see the slide? Just raise your hands if you can see the slides.
Yes.
Okay, brilliant. So what I'm going to concentrate on safe neurosurgery with COVID-19. Why do we need this? Pepe and Zhao has already singled things out. There are many things that we did not do earlier, and now we have experience, and now we know what are the things we need to do to avoid serious problems, complications to people who are operating or people who the healthcare worker who are taking care of these patients. And let me just. This is IFNE group. This was recently in Naples, and on Pepe's invitation, it's great hospitality. So the whole group has already contributed a lot, and we continue to contribute. Not going to go into detail. We've already discussed this. This is a very important slide to understand that among all these, COVID affects about 2.5% of the people. If you get infection, you're going to spread it to 2.5 people. Whereas measles, on the other hand, you can see at one time can spread it to 18% of people. This is much, much more problematic compared to COVID, but at the same time, COVID has caused serious problems. So we need to understand that it is causing serious problems, but it spreads just like influenza. General preventive measures, we have already, everybody has talked about it, and I don't need to go into details about that, but why masks should be worn, why we should be careful in our clinics, in our wards. And you may have an asymptomatic patient, and you need to be careful what you're doing with those patients. So social distance is important. Hang on. Just going to go into this gentleman back in 1865. He was very outspoken for the surgeons to wash hands between surgeries to reduce the mortality. And this person was thrown into an asylum by his colleagues because they didn't want to change. So, if we know that transfemoral surgery or high-risk surgery for us, and we should, until we have good evidence, we should not be performing these routinely unless we have the proper gear. OPD consults already been talked about. Why should we wear a mask? If you've got a problem, if you've got flu, then you should wear a mask. For people who are in the hospital, obviously they need to take care of themselves and they should wear a mask. The most important thing is maintaining a safe distance. Throw away mask once they're grows. Don't wear them again. Bacteria grows on the inside. Don't touch the outside of the mask. You wash your hands every time you put the mask on. Take it off. So the training for N95 is essential in this. This is what we are talking about. If one person is, if none of them are wearing a mask, very high chance of contamination. If one person is wearing, it's still high. There's a medium if one person is wearing who's got a respiratory problem, but if both are wearing, the chances of having a problem goes down to really low. And this is important to understand that surgical mask is like an N95. So 95% viruses and bacteria, 95% of viruses are blocked with surgical mask, whereas the bacteria is only 80%. And with N95, we know that virus is 95, bacteria 100, unless it's bactericidal or some virulent creams, antiviral creams that are being applied, and that becomes N99 as well. So we need to understand that. So FFP3 is what we're talking about. That is N99 mask that takes care of viruses and bacteria up to 99%. All these sponge masks are useless. The cloth mask is really useless for viruses. Active carbon masks only take away 10%. So please do not wear these. And I see many people trying to wear this in theater. Please do not wear these masks. They're of no use to us. We have already discussed this. Not going to go into that. Scheduling cases, postpone elective cases if there is a problem in your own city. Schedule only emergency cases. And you need to have at least one preoperative negative test, if at all possible, then 2 tests with the distance of at least 24 hours, and use appropriate PPE intraoperatively if there is a problem. I'm sorry, I don't know if you guys can see properly or not. Operation theater layout, we have already talked about it, not going to go into that. COVID suspected use of respirators is recommended. N95 for these patients with COVID is not sufficient, but it's an acceptable alternative if you don't have any other choice. Intubation, extubation, we have already seen this box. It's important and it's very simple to make. You can make it even in your own hospital, in your backyard. It's very, very easy. Neuroendoscopy, generally, no, it's not safe. If you have PPRP, then it's okay. If you don't have it, then it's a problem. Is it safe? It's just like flu-like symptoms that patients who underwent transneural tumor surgery in Wuhan. So one patient resulted in more than 14 of the patient care team in that time having the virus and causing serious problems to them. Similar case was done with N95 and the results were similar. And so it's important that unless we have proper respirators, we should not operate on these patients. Do we think we are over-exaggerating things? No. We know that anesthesiologists in China were affected a lot, eye surgeons, ENT surgeons. We have had a lot of deaths in ENT surgeons all over the world. And these are various reports that I've got here, which tell us that it's unsafe to do that. Postpone unless all emergency cases should be postponed. So we are only operating on emergencies or urgent surgeries. And if you're doing urgent, which can wait 5 to 7 days, then obviously what we do is we do a COVID test on them and repeat it in 24 hours. And if it's negative, then we proceed with that. If at all possible, do not do endoscopy through skull base. Don't want to be going through the air sinuses. Endonasal procedures, by contrast, have got a very significant risk. So you have to be very careful. You need to avoid drills, avoid excessive irrigation, avoid body fluid spatter. And all that is important when you're working through the nose or the mouth. So transoral surgery, transphenodal surgery, all that should not be there. If the patient is losing vision, think about doing a craniotomy. Think about a microscope-based transphenodal surgery. And if you really are sure patient does not have COVID and you have done all the tests and you're taking all the precautions, yes, it may be possible. But why take this risk? I think patient could wait a little while until all this is over. If surgery cannot be postponed, you think about respirators. Otherwise, do not do these surgeries because all of you are very important for us. Tracheostomies, I think if at all possible, avoid tracheostomies. There's a lot of spatter, and unless you have same kind of box that we saw in intubation, you should not do that. Nowadays, we're using these boxes also in our ICUs to prevent any spatter coming out when our ICU staff are cleaning tracheostomies. So it's very important that we take care of things, provide adequate sedation, including paralysis, to eliminate the risk of coughing during the procedure. CPR is a no-no at the moment. In COVID patients, do not do a CPR. What's okay now is that you use a full FFP3 mask, you have long gloves, you have eye protection, and if at all possible, if you want to do CPR that way, it's okay. Otherwise, you should not do CPR. All that spatter that comes out will give rise to problem. So filtered N99 mask still has 99% filtration and 2% leak. If you don't have PP, do not resuscitate. Shocks, we should try not to do, because if you do shocks, again, the same thing, the whole thing splatters and you've got a lot of stuff coming out onto your mouth. So I'm not going to go into this because it's already been discussed. Since we already are running short of time, I'm going to move on and we can ask questions. So if you have any questions, you can put those questions on. Let me just go back. Imad, can you help me get out of there? Yeah. Okay. So if you have any questions, just write to us. So I have got a few questions for Pepe to start with. Pepe, are you with us?
Yeah, sure, I'm here.
Okay. So the question is, why north of Italy was affected that much? This is from Vivek from India.
Why, sorry, what?
Why northern Italy was involved this much?
Well, Salman, nobody knows. Certainly, there is a problem of climate that is very different between the north and the south, probably. In the north, there has been, I heard an interview to the chief pneumologist of the Bergamo city, and the very first head of department who had to face the first wave, and he was convinced that a football match between the Bergamo team and a Spanish team that had been played just 10 days before in Milan brought 10,000 people from Bergamo to Milan. That is a 1-hour trip. And he really considered that that situation was a real epidemic bomb. And in fact, when he reconstructed all the timing of contagion for that region, he considered that the simultaneous wave of people arriving in the emergency room on a Sunday afternoon was really related to that epidemic big bubble. Then, of course, there has been a spread. You know that Milan is highly interconnected with China because of business and because of, so certainly some kind of this kind of and the climate. These are the main ideas we have. But of course, we have no certainties.
Okay, there's a question from Sonola, and they're asking about the criteria for quarantine among the medical staff. Did you have any criteria for isolation or quarantine for the medical staff?
Quarantine, you means we call quarantine 14 days off. 14 days off, of course, is any direct contact previous with some COVID positive, certified COVID positive, and of course, positivity or your nasal swab, you have to go out to work, of course, for at least 14 days until 2 successive negative swabs. I mean, they are exactly the same that in every other part of the world. You have to be very cautious, and how to manage the shortage of staff with the cutting all the other activities. I mean, when you cut all the day surgery, when you cut all elective surgeries, you have a lot of anesthesiologists that can go to do your work. We now have, fortunately, in my neurosurgical departments, we have only one guy who volunteered to leave neurosurgery and to go to the north of Italy to take care of COVID patients. So fortunately, we have only one person who is out of the staff. Otherwise, in our hospital, we have no shortage. But it's a pediatric hospital.
There's another question. How can you reduce aerosol when you're using the drill? You just showed that dentist aspirators can be used, but is there anything else that we can do? Should we just avoid the drills for time being?
I think we are creating with our engineer the shield that you see in the dentistry is applied, is a small shield. I am thinking about applying the aspirator to the square box. This would increase significantly the aspiration of every kind of aerosol during any surgery without allowing any aerosol droplet to escape. And we are discussing with our engineer. I mean, there's not a big engineering behind it. It's any kind of 3D printer can do that. And it's very easy to just make a connection between the aspirating tube and the box.
So what about, is there any specific recommendation? There's a question regarding spine. Is there any specific recommendation that you have for somebody who's come in with traumatic spine and needs urgent fixation? Are there any recommendations that you have for them?
Spine, you know, our spine activity in children is extremely rare. We basically manage any spine patient like for every other emergency case. We had other kind of emergencies, and we just manage them with the highest possible PPE protection, knowing that in children in our region in Naples, the risk of treating a contaminated child is extremely low. So we are relatively safe about that. I'm probably not the best person to answer to that question because our level of involvement with COVID, direct involvement, is very low.
Okay, there's another question. Just to remind everybody that we have this discussion for 10 minutes, and then we have Professor Henry Schroeder, which I shouldn't be saying. Professor Henry Schroeder would be giving us a talk on colloid cyst endoscopy. So, and hang on there. So there's a question about PPE adverse effects, psychological effects of PPE, and the surgical performance. Do you think the psychological effects are significant, and do you think the surgical performance goes down with them?
Yes, especially with the new generation. People who have been using that told me about the big difficulties of communication, first of all. So you have to create some kind of communication, because otherwise you cannot communicate by sign or screaming. It is very difficult. And other people talk about significant physical stress on the face. I mean, this is has been seen by everybody. Very long procedure are a little bit problematic with such a PPE. That's why you need a PPE that is the best possible protection and very easy to wear. That's why nurses has no more glasses, no more stuff. They just have this very large stuff, and this is fantastic with the fresh air, because the motor is also able to reduce the temperature of the air. And that is probably the best way to allow nurses who have to spend 12 hours with the PPE. And in China, we heard the stories about the fact that nurses were using Pampers to avoid to change. I mean, unbelievable stories. And I think that some of them are true. I mean, it's because when you are in real shortage of PPE and you have to stay for 12 hours working, you have to find some solution like that. And this is amazing. This is crazy.
Okay, there's a question actually for Pepe again, the difference in precautions when you're operating in an adult or a pediatric patient, and is there any specific difference there?
I think so. I think so. I mean, but I cannot tell the difference because I'm only operating in a pediatric setting. So probably you or Zhao or Henry are more better placed for what kind of difference you make between children and adults. I have no idea. We always use double gloves now. We always use very N95. I mean, we are using every kind of precaution during surgery. I don't know if I would do any difference between an adult and a patient.
Actually, for us as well, there's no difference. There's a question that if you've had a lot of asymptomatic doctors who have got infected, and now they might have developed antibodies. Can we use them to be on the front to avoid further problems with doctors?
Antibodies. We try to make an epidemiological study in our hospital for the antibodies, and most of the doctors who had positive IgM were revealed to be negative in the swab test. So we do not rely very much on the quick test on the antibodies. And for the more reliable method of blood sample, unfortunately, we have not enough, and we could not conclude any epidemiological study. So we do not know how reliable they are in my personal practice.
Okay, very good. So there's another question that, there are non-symptomatic cases who are contaminating. Do you know of anything that has come in recently which may detect all these cases early? And is there any particular time that you are able to detect this when you're doing PCRs? Can we detect them day 1, day 2, day 3? What is the best time?
No, I'm not up to date with that. I mean, this is a highly specialistic, and I rely on what my sanitary direction says.
Okay, so generally nowadays they say that you have to wait 5 days before you do PCR, because otherwise if somebody gets infected in our hospital, they're sent home and their test is done day 5 and day 7. And that's what they want to know, that, are they infected or not? And then they decide how long they're going to isolate those doctors. The question is, I can answer that. Should we avoid endoscopic skull-based surgery and CSF leak repair? Yes, definitely. I think unless you have really no other way and you're 100% sure the problem is you cannot be 100% sure that it's COVID negative, because even if you do test on, whenever they come in, if you're doing on day 1, day 2, day 3, you will not get that, but you will really find out after 5 to 7 days. So at the moment, I think it's very, very difficult. Try to, if at all possible, try to do them from the top, if it's really emergency. Otherwise, if you have all the gear and you feel very safe with that gear, then use that. But otherwise, I think there is no point taking the risk. I have suggested to our president not to please indulge in fun while doing this, because I feel it's very important that all of us have taken a lot of time to train, a lot of time to do lots of stuff, and you can really make a difference in future. Waiting a month, 2 months, 3 months before you do any exciting surgery, I think you can still wait. I think it's good that we are done with all our questions and just in time. Henry has been waiting whole hour, so we get him up. Henry, you're next, off you go.
Okay, Salman, thank you for organizing this meeting. In the name of the IFNE, I welcome everybody. And I think the topic of COVID-19 is very important for all of us. So now we come to a simple topic about colloid cysts. I think colloid cysts are really a nice indication for endoscopic treatment, but you have to have several precautions. Otherwise, you can do harm to the patient. You can be not successful. And this, of course, is what we don't want to have. So everybody knows a colloid cyst is a benign lesion, usually arising at the roof of the third ventricle. It's of endodermal origin and has a mucosinous content with various viscosity. And everybody of you probably had such a case with a sudden deterioration, and the patient maybe die from such a benign lesion. And this is, of course, what we want to avoid. So what is an indication for surgery? I think everybody is agreeing that all symptomatic cysts are a clear indication to do it. In younger patients, we are very aggressive with surgery because in younger patients, usually the cysts are progressing over time. On the other hand, we have a lot of old patients, which we observe for many years now, and the lesion is not growing at all. So if I have an asymptomatic cyst with signs of CS pathway obstruction, that means ventricular dilation. Even if the patient has no symptoms, we would advise surgery, especially in the younger age group. If it's an asymptomatic patient and you see the ventricles of normal size, we do a cyst MRI in the coronal plane, and usually you see there's space between the cyst and the fornix. That means the foramen is open, and then there is no need for surgery, and you can observe them. And as I said, many patients will not have any growth over many years. But sudden death is a problem. That's why we have to take care. So, you know, many of the initial reports about endoscopic treatment of colloid cysts stated that the total resection of the cyst is not possible. But is this really true? You have known many newer reports presenting a total resection of the cyst. So is a safe endoscopic total cyst resection possible? It is, yes, but there are a lot of precautions which we have to take. The most important thing is, of course, how we can avoid complications. And this is what I want to discuss with you. So most important is that you have really an equipment which allows you to deal with a colloid cyst. Accurate patient selection is of utmost importance to prevent failure. Entry point has to be selected at the right place. Bimanual technique is very important, in my opinion, and sharp dissection. So we should not only pull on the cyst, but mostly sharp dissection. Retraction with an endoscopic trocar is an endoscopic sheath, is very important because you get more space and you can retract, for example, the fornix to get access to the third ventricle. For hemostasis, we use a small channel irrigation technique and the dry field technique. So the equipment, when we designed the ventricular scope with Karl Storz, my prerequisite was that we have a large working channel. That is very important. And we have an endoscopic sheath. The trocar is put into the sheath. We can puncture the ventricle. The trocar is removed, and then the endoscope goes in. So this protects the brain tissue. And the sheath, as I said, is very important for me also for dissection and retraction. And the ventricular scope, what we use has a diameter, a working channel diameter of almost 3 millimeters, it's 2.9. And this accepts large instruments, especially a suction tube, which is very important to evacuate a colloid cyst in a very efficient way. And then we have two side channels, and one of them we frequently use a forceps to have a bimanual working technique, and the other channel is used for irrigation. And this is the suction tube what we use to aspirate the content of a cyst. It's a suction catheter. The diameter is 2.7 millimeters. That means Chaillet number 8. This is collected from the anesthesiologists. They use it for kids to make an endotracheal suction. That's very efficient, and it's a soft suction tube which will not damage any surrounding structures. And I prefer to have a mechanical holding arm, so I have both hands free for dissection. If you have a very experienced assistant, of course, he can also hold the scope, but in my opinion, this pneumatic arm from Mitaka is very helpful. You just press this golden button here, and then it's very easy to position it. And of course, you need an HD camera to have a very good view. And you know, with these HD cameras, you even can see erythrocytes going to the vessels. So it's a very high resolution. And then neuronavigation should be available if possible. It is a very, very helpful to have the ideal trajectory. So in most of the colloid cysts, we just want to slide over the head of the colloid nucleus to come from an anterior trajectory to look to the foramen and to the telachoroidea. With navigation, you can really find the ideal entry point and have a very good approach trajectory. And then you should sit convenient. We have one screen with the MR images navigation and one screen with the image. And we have a screen for our students, residents, and also for our guest doctors. So what about patient selection? I think initially we tried really in all patients to make an endoscopic approach, but now after many years of doing it, I think this is the wrong decision. So patient selection is very important. So we have to look, what is the size of the ventricles? Is there an asymmetry of the ventricles? What is the size of the foramen of Monroe? What is the size of the colloid cyst? What is the content? Is it a dark content in T2? Then you know aspiration might be difficult. Sometimes it is iso-intense on T2, and then it's easier, or even hyper-intense, and it's a good sign that there's really a fluid which can be easily aspirated. Colloid cyst location is important. Some cysts are located directly in the foramen, some are located more posteriorly, and some are located mainly in the septum. So all that is important. So the relation of the cyst to the fornix and the veins have to be considered on the preoperative MRI. So it's really an individual selection of approach and technique depending on the patient. So one example, this was a 13-year-old girl presenting with headache, vomiting, and she became drowsy. And at that time, there was no facility to deal with a cyst, so a shunt was placed. In general, I would say we never do a shunt in a patient, but if you have not the options to deal with a case, this is a life-saving maneuver. And then the patient came to us for consultation. You see what happened because of the cyst. This ideal case for endoscopy switched over into a difficult case for endoscopy because there are slit ventricles, and you see even because of the hyper drainage of the shunt, there is slit ventricles and subdural hygroma. So in my opinion, this is not a case for endoscopy, even though you could place a ventricular catheter, dilate the ventricles. I think this is clearly a case for transcallosal microsurgical cyst removal, and that is what we did. You see here, this is a defect in the corpus callosum, about 1 centimeter. The shunt was removed in the same setting, and you see the ventricles expand, and the girl is doing well. So if possible, don't place a shunt into such a case because you make it much more difficult to deal with the lesion. That was a lady transferred to us after an unsuccessful attempt of endoscopy. And there was a ventricular catheter implanted with a boho reservoir. And I said, or I looked at the image and I said, why this failed? The cyst is located at the foramen. If you look here, seems to be the fornix is on the right side covering the cyst. The left side seems to be okay. So then we asked for a cyst sequence to have a better image to the cyst, and you see this seems to be the fornix covering the right side. The right foramen is small, the left foramen should be large. So I said, okay, we try it, but we prepared everything for microsurgery because the surgeon at the first surgery could not deal with the cyst. So maybe it's something wrong, but from the image, I think everybody, Pepe, what you think? Looks like a good case for endoscopy, right?
Yes.
So we came in, and surprisingly, the cyst was completely covered with a very thin layer of fornix tissue. So this is fornix, and this is also fornix. This is a lesion caused by the ventricular catheter tip, which was inserted a little bit too deep. But this is all fornix. And then I thought, in my hands, it would not be good for the fornix when I try to do now an endoscopic procedure. Of course, there are reports, you can open the choroid fissure and so on, but you see there is no space. So in my hands, it's much safer when I switch to microsurgery, put a pedi, open the septum here, gently dissect the fornix to the lateral side, and then go interfornicial to remove the cyst. And this is what we done in this case. Another patient, headache, nausea, vomiting, and you see this image. You see ventricles are wide, ideal for endoscopy. But if you look here, you see a vein here, and you see the vein here, probably the septal veins. So this should be the foramen. And I talked to the patient. I said, we will start with an endoscope to have a look, but this will be a microsurgical case. And you look at the coronal view, you see here, there is the leaves of the septum. So this should be, it should be possible to make an interphonicele, although I hate interphonicele usually, but if the phonicles are separated, not very close together, then the interphonicele is a good approach. And also the content is black, so we expect a firm content. So approach from the right side, endoscopic view, you see this is all fornix. Here is the cyst, and this is the foramen. So I pulled out the endoscope, and we have this translucent endoscopic sheath. We just follow it. It has a diameter of 12 millimeter, and we have a good look. This is again this is the endoscopic image. You see, this is all fornix over the cyst. So I switch to microsurgery. We cut the septum, and then you see this is the left fornix, right fornix. With a diamond knife, I could carefully separate it. They were not very sticky together, not a thick tissue, neural tissue in between. And then the most important thing is to find the right plane. Frequently, we pull too much on the telachoroidea. We have to find exactly the plane between the cyst. You see, this is the cyst, and this is telachoroidea. This is only a very small, thin layer of cyst, which has to be removed. All other tissue is telachoroidea and should be preserved. And then a bimanual technique. Is the video running well, or do you see it not in a good quality, Pepe? Is it okay?
For me, it's excellent.
It's good.
Okay, here sees is a fornix, and this is a patient where we made in pre-op and post-op neuropsychological investigation, and he did not get any harm from this interphonicele dissection. And post-op, total resection. So I think not all patients are good indication for endoscopy, and we have still to consider that microsurgery is a good option. So the entry point, if you consider a purely endoscopic approach, this is our head position. We always position the patient that the burr hole is mostly at the highest point, that we don't lose too much CSF. We don't want to have air in the ventricles. Usually it's behind the hairline for cosmetic purposes, or in patients with bald head, we use a wrinkle to place it. And this is an approach which allows you to slide just over the head of the colloid nucleus. So initially we made this standard precoronal burr hole like we used for ETV, but you look, if you see the colloid cyst, you have a tangential view to the cyst, you look to the floor but not to the roof. And this of course is wrong and should not be done in these cases. We make a planning of the approach far anteriorly, far laterally. So we slide over the head of the colloid nucleus and we have a look at the roof of a third ventricle. That is the ideal approach. And then usually we have a good view to the colloid cyst. The only exception is if you have a cavum, then you can go directly into the cavum from the precoronal. Then you see the foramen usually is small, and then you open the septum here in this area and you can look on top to the cyst. But in most cases nowadays, I would prefer to make it microsurgically. What is else important, in my opinion, is a bimanual dissection technique and sharp dissection technique. For that, we use a flexible forceps. The flexible forceps is introduced via one of the side channels of the scope, and the main instrument is introduced in the main straight channel. And then you can elevate the cyst. You elevate the cyst with a forceps, and you can cut the cyst wall, and you have no danger to cut into the fornix or in the veins. So I think the bimanual technique for colloid cysts, in my opinion, is really helpful in many cases. So it's one case, you see the first step is we have to mobilize the cyst out of the ventricle, but then you see there are a lot of vessels in the telachoroidea, usually attached to the cyst, and we have to deal with that. So we can coagulate these vessels, but the pedicle is always going down if you leave the cyst. So I pull the cyst with a forceps, introduced via the side channel of the scope, and then I come with a bipolar via the main channel and also with scissors. So I pull the cyst up, and in that way I get access to the pedicle. And there's no need to simply pull on it to remove it, but we cut here. You see the telechoroidea is very thick, very adherent in this cyst. So we have to really dissect it to remove the cyst in a safe way. And then you can achieve a gross total resection. You see there's almost no damage to the fornix. There's a little bit damage to the ependyma, but the neurostructure of the fornix is completely intact. So the next thing what I use is retraction with endoscopic sheath. I like it. If the foramen of Monroe is of adequate size, of course it must be large enough. If it's too small, it's not working. I can go in with my endoscopic sheath. I pull the camera back, so the endoscope tip is around 4 millimeters back into the sheath. I have control over the edge. I go into the foramen, and then I push the fornix away, and I get access to the cyst wall under the fornix. And that is very helpful in many instances. Small chamber irrigation technique is a term which one of fellows from US has given to the technique. What we use, it is a small chamber irrigation technique. It simply means if you have a hemorrhage, we use irrigation. Usually we have simply a syringe attached with this tube. You can also take a pump, but we usually have simply this irrigation syringe and tube, and we fill it with lactated ringer solution at body temperature. And then for hemostasis, we have a forceps and we have a bipolar diathermy rod. So the bleeding starts, you don't see anything, and we start with irrigation. So we have forced irrigation, then you get a glimpse of the structures, and we approach the bleeding point with our endoscope. And when we are close in front of it, we bring the endoscope tip back, so we withdraw it into the sheath, and we create this small chamber. And this small chamber can easily be free of bloody CSF by irrigation, so we have a good view. We can see the bleeding point, and then we deal with bleeding. So one example is a colloid cyst. You see there is an artery attached to the cyst. I have to pull with one forceps. It's a bimanual technique to get the vessel into my working field. And then with a bipolar diathermy probe, I coagulate this artery several times. So by manual technique, coagulation. And then I thought I would be done with the artery, and then, oh shit, was too early. The vessel was not coagulated well, and you see what happens is we have a red image, we don't see anything. So what we have to do now, we start with irrigation, forced irrigation, and then we get a glimpse of the structures. I go back with my endoscope into the sheath, create a small chamber. You see here now I see the edge of my endoscopic sheath, and I use it as a retractor. I retract the fornix a little bit backwards to get access to the telechoroidea of the third ventricle, where the small artery is arising. Otherwise, I would not get access to this vessel, and I have to irrigate at least half an hour, I guess, until it stops spontaneously. So with this small chamber irrigation technique, retraction of the fornix, I can deal with it very easily, and I can continue with my surgery. And you see there's no damage to the fornix. And the last but not least technique which we use in severe hemorrhage is a dry field technique. We published this first in 2002 in our small series of endoscopic choroid cyst resection. And then Joachim has put the cases together, what we had over the years, and published this in JNS last year. And here is one case. There's a miscommunication between me and my assistant. He should only rotate this endoscopic sheath, but he pulled on the forceps, and then we have this severe venous hemorrhage. And this, of course, looks very, very ugly. We started again with irrigation, but you see, if you have this Japanese flag sign, then it will take a long time to clear it, if at all. So what we use is the suction tube, and we simply remove the bloody CSF. and immediately you get a good view to the structures. And in all cases where I had used it in colloid cysts, there were 4 cases so far, and in all of them, the bleeding stopped without identifying the bleeding source and without the need for coagulation. I coagulated simply here, but this is just a clot. There's no bleeding vessel. So just removing the CSF enables the natural clotting mechanism to occur, and then you can continue the surgery. Usually we refill the area with water, and you see no damage to the fornix, although there was completely red out from the venous hemorrhage. So I just want to show you some endoscopic cases. This is one guy with headache and nausea, and you see there's an asymptomatic dilation of the ventricles. You see it's a nice colloid cyst. The content is not black, it's a little bit iso-intense to the brain. And you see the right fornix is covering the cyst, but on the left side there is space. So this is a good case for endoscopy. I think everybody's agreeing that we take the left ventricle to approach it. Navigation is used to plan the approach. And you see, this is an ideal case. Because we come from an anterior trajectory, we have a good view to the foramen. There's no choroid plexus. It's a very thin cyst. We open the cyst with scissors. We have a suction tube, and you see, because of the large diameter, it's very easy to evacuate. Just 5 seconds, cyst is empty, irrigation, and you see cyst pops out. But unfortunately, it's not always that easy that the cyst is coming. There are some attachments, so we coagulate a little bit the choroid plexus. Then we have this forceps in a side channel. We mobilize it, and we have another forceps in the main channel. And we carefully lift it up. And this was really a very easy case because there was no major vessel attached to it. The only adhesion to the telachoroidea is this fibrous band. That's it. So initially I thought to cut it, but then you see, we just pulled on it. Of course, better. It would be better. It looks better when you make a cut. But you see, this was not adherent to anything. The fornix looks good. It was very easy surgery. Took only a few minutes. And then the post-op MRI shows a total resection, and it's now over 12 years. No, it's over 12 years, I think. And he's doing fine. There's another case. You see large ventricles, black sign in the cyst. The size of the foramen of Monro looks the same. Then always we prefer to come from the right side. Large ventricles. And you see the cyst is appearing in the foramen very nicely. So that's why we made the decision to come from the right side. See the cyst in the foramen, choroid plexus, coagulated with a bipolar diathermy rod. Then we incise the cyst. And again, you see here with a large suction tube, it was easy to evacuate the cyst. And then we have to mobilize the cyst into the lateral ventricle. So not more cyst content coming. You see the cyst content is not so easy to aspirate, only a part of it, but this one is very firm. But now it's very important. I have to stop this. It's very important when you remove a cyst that you only grasp the wall of the cyst. Try to avoid grasping the choroid plexus and try to avoid grasping the telachoroidea. Otherwise, you will get the hemorrhage. If you grasp just the cyst, you see how nicely it's coming out, and the pedicle is only this area here. So you have, again, the bimanual techniques. There's choroid plexus adherent. Now I use the endoscopic sheath as a retractor. So I push the cyst upwards in front of the foramen to get access here to the telachoroidea, close to the thalamostriate vein. So I cut it, and again, I cut too early. See, there's a bleeding. It's not very large, but it's bleeding. So initially I trying to simply coagulate it, but the vessel was under the cyst, so that's why I used the dry field technique to make it quicker with the hemostasis. You see, I remove the CSF, bleeding stops, and then again I grasp the cyst wall, and you see this is the only small telechoroidea. Refilling of the ventricles to prevent collapse of the ventricles and to enable also use of the bipolar, which is working underwater. Coagulation of the pedicle, and you see I use my endoscopic sheath as a retractor. I have a very good view to the pedicle, and then sharp dissection is used to have a complete dissection of the cyst. The endoscopic sheath is too small, so I have to pull the whole system out because the cyst content was very firm and could not be completely aspirated. And you see, when we look to the fornix, it looks good. This is a 45-degree endoscope looking to the telechoroidea, and there's no significant damage to the fornix. So these are very good indications. Just one case for discussion, and then I'm finishing. This is a guy who has signs of chronic hydrocephalus, so gait disturbances, memory, the same like normal pressure hydrocephalus, so chronic hydrocephalus. You see white ventricles. Pepe, what approach would you choose in this case?
I don't know. I would do the right one, right transforaminal. I think that you can. The foramen is very, very small, but
yes,
I think that if you manage to decrease the volume of the cyst, you can manage to access the foramen anyway.
Yeah, if you look to the content of the cyst, looks very nice, like CSF. So it should be very easy to aspirate content, except this small part here.
Yeah.
But when you look here, the size of the foramen is so small. If it's very adherent, I thought it might be a problem in the dissection. So initially I thought maybe I make an interfornicile approach to come on top, but there is not a very good separation what you see here. So I thought I start with the endoscope, but I do not come very far from the front, but more from here, that I have also the option to make a transchoroidal approach. So that is a view what we got with an endoscope. You see, this is fornix, all fornix. I said, no, I cannot cut in this. And I looked with a 45-degree endoscope to the foramen of Monroe, and you see it's very, very narrow. All is neural tissue. This is all fornix running over the cyst. And then I said, no, I don't try it. I just remove the endoscope, and then I bring this translucent sheath inside. It's 12 millimeter in size. It just follows the endoscope track, and then I dilate the ventricle with a bimanual technique gently, and then I have this shaft instrument, and I cut the cyst, and you see it comes easily out. When I have seen this, I always think, like you said, Pepe, maybe I should use it, I should do it in a purely endoscopic way, but maybe it's a little bit quicker and a little bit more less traumatic to the fornix. And you see again, you grasp the cyst wall. This is all telechoroidea. This is a cyst wall. And now if I grasp the cyst wall, the cyst comes out so nicely. And this is just this short pedicle. Short pedicle, coagulation with bipolar diathermy, and then cut with scissors. You see, this is all telechoroidea. It's not the cyst. And then I cut the last adhesions, and I can bring the cyst out. This is the last piece which was black on the MRI. And you see foramen looks very good, and then I use an endoscope for inspection. This is a chiasm, lamina terminalis, infundibular recess, and this is the posterior part of the third ventricle, just to look that there is no debris, and then we remove the small endoscopic sheath, and I close the cortical tract always with fibrin glue to avoid an accumulation, subdural accumulation, and you see good flow here. It's a very early MRI. This is another case. This was a patient coming to me complaining about headache and nausea. And you see, this is a very tiny colloid cyst. And I sent him away. I said, no, come on, this is not symptomatic. You have other problems. And he came back after 6 months, after 1 year, after 2 years. He was always complaining. He had problems, intermittent headache. I said, maybe it's doing a problem. Is this an indication, Pepe, Salman?
Nope. I'd look for other causes.
I did for 2 years, and he always coming back complaining. And you see, he has a very small foramen, sometimes in pineal cyst. We have also almost the aqueduct is open and patients suffering from headache.
Yeah.
If you look to this image, the cyst is far back from the foramen. So if you want to approach that, the only approach is a transcallosal. And he was really make me nervous all the time. He coming and complaining, and then he said, okay, if you want, we make a transcallosal approach. We plan it. Opening. See the pericallosal arteries. Navigation was very helpful to find the best trajectory to the cyst. So we open the corpus callosum, going into the depths. And then you see there is no foramen. So endoscopically, this is impossible, in my opinion. And at the foramen, it's not appearing. I looked at the foramen, no, it's not appearing. So I opened the telechoidea on the thalamic side, not on the phonical side. It was much easier, and there was a cyst. And you see the content is very, very firm. And then carefully, I removed the cyst from this area. You see the content coming out, and then finally all the cyst comes out easily, was not very adherent. What do you think? What is the patient saying after surgery? The pressure feeling is gone, but he has still headache. So we published our first cases in right neurosurgery. There were 20 patients, and we had in 3 patients, we had to leave a cyst remnant behind. And in 2 of them, there were progressive recurrence. In 1 case, the residual remains stable. But if you have to leave a cyst behind, there's a risk of recurrence. That's why I always try to have a gross total resection. If it's not possible endoscopically, microsurgically, usually it is. And this is 16 patients which we selected to our criteria. All had occlusive hydrocephalus, except 1. He has normal ventricles. And we could remove the cyst in 15 of them. In 1, we had a near total resection. It was an old lady, 75 years old, and she requested the most safe procedure. So I left a small piece at the internal cerebral veins. But we had not to change to microsurgery, and so far we have no recurrence. So I think if you have precautions, a gross total resection of colloid cyst with a channel endoscope is possible and may result in very good outcomes. We had no mortality, no permanent morbidity. We had 1 patient who presented with memory deficit, and he complained it got worse, but did not improve. And we had 4 venous hemorrhages, and all were endoscopic controlled with a dry field technique. So my conclusion is, in most colloid cysts, a safe endoscopic total resection is possible if you have a good patient selections. I think patient selection, as always in surgery, is of utmost importance. And we can avoid complications by careful planning and dissection. And finally, I want to invite everybody to our interim meeting in India. I hope in September we can do it, but I'm not sure it will be possible. Thank you for your attention.
Great, Henry, it was wonderful. I think excellent talk. Danny Papadello just messaged me saying this is a wonderful talk as well. So he's among the audience as well. We have a question from Sandy to start with. You showed a fibrin glue technique for occluding the transcortical tract. How do you control the location of the fibrin glue so it does not spill into the ventricular system?
Yeah, when you have a big hole, you cannot do it. But if you have a small hole from this 12mm tube, spontaneously the brain collapses already. And then I start with the glue at the beginning, at the surface. So I don't inject it into the depths, then I think it can fall down. But I start at the periphery, and then I go around with it. And this will prevent that it is goes down.
Okay, so there's a question. Yeah, sorry.
Yeah?
There's a question about causes of sudden death. You know, this theory about sudden death with colloid cyst. So do you know of those causes, or are there any causes that can cause sudden death with colloid cyst?
Causes of sudden death?
Yeah, because, you know,
no,
if you remember,
the cause is that the cyst is occluding the foramen of Monroe. And we had one patient who had a minor car accident, so like a small contusion of the head. And he came back after 5 hours after the accident with a decompensation of this hydrocephalus. So usually the patients all have hydrocephalus. I have never seen a patient with small ventricles who suddenly deteriorated with sudden death. So usually they have pre-existing hydrocephalus, and this can decompensate by minor head injury, for example, or by activities, or what we had. I was a reviewer for a court for a lawsuit, an expert witness, and they made lumbar puncture without a CT scan in the patient because they suspected to have a meningitis, and this patient immediately herniated after the lumbar puncture.
Okay.
But the cause is just the compression and occlusion of the foramen of Monroe.
Okay, there's a question from Hassan Masood, and he's asking, what are the radiological tests that you do to decide, would you go microscopic or endoscopic?
One more, the question, please repeat.
What kind of MRI would you do to decide microscopic versus endoscopic? What makes you decide you'd go endoscopic in this one and microscopic in this one? 1, 2, 3.
Yeah, so for me, the most important sequence is T2 weighted in the coronal plane and in the sagittal plane. Sometimes we use cyst, but cyst is not differentiating very well between the fornix and the cyst, as you have seen in one case what I showed you. But your regular T2 weighted sequence shows you the content of the cyst. Is it black? Is it hyperintense? Is it iso-intense to the brain? Showing you, gives you an indication what is the content. And then you see in the coronal view very nicely what is the distance between the colloid cyst and the fornix cyst.
Okay. There's another question by Adnan Khalek, and he's asking, what are the clinical features that you see if to decide you're going to go microscopic or endoscopic?
Clinical features doesn't play a role. It's just the MRI.
Okay. You talked a lot about the black content. What does that signify?
That means the black signal in T2 means that the content is very firm. And sometimes you have cases where you cannot aspirate the content with a tube, but you have to take grasping forceps. And I had a very big cyst in my initial series and experience, and I tried with an endoscope for 2 hours, but it was useless. And then today I would start microsurgically with a tube if the ventricles are white, or if the ventricles are narrow, I prefer the transcallosal approach.
I'm sorry, but one of the gentlemen is asking about what companies are making these tubes, and which one would you recommend?
Oh, the company, I don't know, to be honest. The name is SideView. Maybe Pepe knows.
Sorry, I missed the question. Can you repeat?
The tube that we use for going in instead of endoscope, the glass tube or the plastic tube that we use.
No, I have no
Vicor makes them. There are many companies who make them.
Vicor is correct.
Yes. Vicor. Yeah, Vicor.
We use ordinary 5 ml, 10 ml syringe to operate here. We cut the end at the lower end. We make it a Vicor, a cheap Vicor, and we use that. And it's very cheap. It's like, I don't know, 2 pence or something.
Also an option, yeah.
Yeah. The other question is, what are the pitfalls of endoscopy in colloid cyst?
The pitfalls?
Yep.
Now, I have shown there's a hemorrhage. Usually it's a hemorrhage which causes a problem, especially the veins are adherent to the cyst. And if you pull simply on the cyst to remove it, and usually you cannot only grasp the cyst wall initially. You grasp always core plexus or the telechoidia, and then you have this problem with the hemorrhage. And then the next pitfall is the damage to the fornix. So you have to be very careful when you insert the instruments, even if you remove a cyst. If a cyst is very large, I would never advise you to make a gross total resection in one piece, but you have to open it, aspirate it, because if you pull it through the foramen, this can also damage the fornix. So I would never advise. Charlie Tilio said he said in one of his papers, he can cut the right fornix with impunity, or but I think this might cause problems. And I have seen patients with memory problems when we had lesions and at the fornix. It was not colloid cyst, but was tumor removal or other things. I think we have to be careful with both sides of the fornixes.
Okay, another question regarding the approach, endo versus micro. Is it the size of the cyst that matters, or the ventricle that matters, that you're going to decide you're going to do endoscope or microscope?
Of course, if it's a huge cyst, I had one huge cyst 4 centimeters, then maybe the size matters, but usually size does not matter. What matters is the size of the foramen of Monroe and the width of the ventricle. So if you have slit ventricles, like in this girl from Cairo, what I showed you initially, you have no chance with an endoscope. And I would not try to play with the ventricular catheter to enlarge the ventricles to get access with an endoscope. That's, I think, is the wrong decision, because you can easily dissect it with a transcallosal approach in a much safer way. So that, I think, is the problem. And of course, the cyst content, when it's really hard and you cannot aspirate it, and it's a big cyst, and you try with a small endoscopic forceps to remove it, it takes hours. So it is also not advisable, in my opinion. And the coverage of the fornix, of course, if the cyst is totally covered by the fornix, then microsurgically, I think you have much better abilities to protect the fornix with a small paddy. By manually, you can push it to the side. So we should not force everything to endoscopy. I think this would be a mistake.
There's a question about dry field technique. And the question is, if you do that, can you cause subdurals to form? When you dry the whole thing, would you have subdurals?
Yeah, I think that would be a risk if the cortical mantle is very small, but in none of our cases we had this problem, because initially we immediately fill it again with CSF, and we fill it into the ventricles. We don't irrigate in a subdural space, but we irrigate into the ventricles, and then the brain expands and it comes close to the dura again.
And your indications for not operating on patients with colloid cyst?
Old patients. I have seen old patients. You know, in Germany, we make too much MRIs, and people who have a little bit headache or have other reasons for the MRI, and you see a small colloid cyst, foramen is wide open, and there is no CSF obstructions, and we just observe. And I have patients, I follow them for more than 10 years, and there's no growth. And there's a nice paper from the Mayo Clinic, and showing the same, that you have old people with small cysts without CSF pathway obstruction. You just observe, that's it. I cannot hear you, Salman.
Yeah, sorry, I muted myself, I apologize. So we have more questions, but before I go on to those questions, it's our next week, weekends, Saturday 25th. We have our famous Sandy Lamb, and we have Adrian Kakaris, and they both are going to be talking about complication avoidance and management in neuroendoscopy. So it's going to be a joint talk. You all are most welcome. Same time that we had today. It's going to be the same time next Saturday as well. So you all are most welcome. We carry on with our questions. There's a question of, if the cyst is located 1/3 onto the foramen and 2/3 posterior, what would be the best way of doing this endoscopy? Is there any particular trajectory that we need to take?
No, if the cyst is appearing in the foramen of Monroe and you get access, then of course it makes no difference if it goes a little bit back, because it's one cavity, you go in, you evacuate it, and then you slowly mobilize it into the lateral ventricle. But if the cyst is only located posterior to the foramen, then you have to make a trajectory from far anteriorly to get there. And if the ventricles are very small, like in the last case, what I showed you, I think a transcallosal, transchoroidal approach is best, because if you have not the trajectory correctly chosen and you want to go to the back, you have to manipulate the fornix a lot, and this might cause damage to it.
Okay, there's a question. How frequently the remnants we leave behind would cause problems or become symptomatic later and would require resurgery?
Yeah, in the last 16 cases, I had just one old lady, and I left really a small piece which was adhering to the veins because it was her request. And even the indication for the surgery was weak because she has Alzheimer's disease, but ventricular dilation. And then she requested to be very careful. Interestingly, when we looked in to the ventricle, we saw that the cyst was not occluding the foramen completely. It was a big gap. But we removed the cyst, and after 3 months post-op follow-up, the ventricles became smaller, what I did not expect. But usually we always try to get a gross total resection. And in the last 16 patients, we have no recurrence. And in the initial series where we had to leave capsule remnants behind, we had 2 progressive recurrent cases. So my opinion is our aim should be gross total resection with microsurgery or with endoscopy. It doesn't matter. We have to compete with the microsurgical series, and they are very good. They have all a good high rate of gross total resections and also a good clinical outcome.
Okay, what are the tricks you have already shown with telechoroidea and how to avoid complications when and there are vessels coming in for telechoroidea? Any specific tip that you want to give? Just one tip.
By manual dissection, by manual dissection, get control of the pedicle. So if you lift the cyst up with one hand, you have always access to the pedicle. You can coagulate it and cut it. If you have only one forceps, you grasp the cyst, it looks good, then you leave the cyst is falling down into the foramen and you have no access to the pedicle. And then so you have frequently you see videos where people just pull on it. And that is, I think, not the right, correct, in most cases, not the correct technique.
Okay, we have same question asked by 2 people, Adnan and Lal, and they're asking, do you recommend ETV in the same setting when you're removing the colloid cyst?
No, never, because in my cases, always the cyst is occluding the foramen of Monroe, never the posterior part of the third ventricle, never the aqueduct. And that's why, in my opinion, it is ill-advised, because in my cases, the third ventricle is very small. It's a very sick, normal appearing hypothalamus. And I would never go through this normal hypothalamus because this can cause also endocrinological problems, obesity or if you have a colloid cyst which is extending into the posterior part of the third ventricle and is causing triventricular hydrocephalus, of course, it's a perfect idea, but I had never such a case in my experience.
Okay, I think the good thing is that Chandrasekhar Devpujari is also here, and along with Danny, and both are saying that cutting the fornix may not be a very good idea.
Yeah, I agree.
Okay, and then there's
we never leave a ventricular catheter behind, never. I just make an observation with a 45-degree endoscope, and usually the ventricle is clean. So if there would be a big clot, then maybe we have a problem, but I always try to remove the clot with forceps so that we have a free aqueduct.
Okay, do you take consent for microscope when you're doing endoscopy at the same time? Do you take consent beforehand regarding that you may have to do something with a microscope if you felt at that time it was required?
Yes, always. Even in cases where I'm pretty sure I can get an endoscopic resection, we get consent to make microsurgery. But in the cases what I showed you, I made the decision before. I said to them, we make an endoscopic inspection, but the preferred technique will be microsurgery.
Okay, brilliant. I think we are done with all. I think we have just one last message, and that's saying thank you very much. What a wonderful, it's Luigi saying that wonderful presentation, excellent. So I think any comments, Pepe, before we wrap up?
No, I think it's. I think we can close. I mean, I have no for the dry field technique. The only thing I do more when I remove the fluid. At the same time, I inject some air in order to avoid ventricular collapse. In one occasion, my working channel was my aspiration channel was partially occluded, So I feel safer to inject at the same time some air in order to balance the pressure. This is the only thing I could possibly add.
Mm-hmm.
Well, you don't think Henry gave a nice presentation?
No, no, absolutely.
As usual.
Congratulations, congratulations. It's fantastic.
I think we must congratulate everybody. I think everybody gave, Zhao was brilliant. He gave us a lot of wonderful information.
And you, Salman.
Was wonderful. I'm sorry that we were running out of time and we were pushing people, but I wanted to make sure that we have enough questions at the end. And hopefully we should be able to have a very good session next weekend as well. So looking forward to that. You all are most welcome. If there are any feedback, you can just, we have our group, just send the feedback and we'll be happy to answer. We are trying to arrange CME for this. You should have it when we do this on next Saturday. So we can send the certificates to the participants straight away via email. And hopefully we should be able to do that.